Thank you very much, Professor Ali. My presentation will be telemedicine in IBD and update. Our agenda will be an introduction, type of telemedicine, application in care of IBD patients, limitations, and take-home messages. First of all, what's telemedicine? Telemedicine or telehealth is a medical service provided from a distance, consuming wired or non-wired means of communication. And nowadays it's becoming popular, and everybody nowadays is using telemedicine in some way or another, thanks to the increasing demand of social distancing by COVID-19 pandemic. Both healthcare providers and patients started to implement the methods of telemedicine and gradually replace some of the previously practiced face-to-face clinical services by a telemedicine service. Also, medical societies promote the widespread use of telemedicine whenever possible to ensure the safety of the community during the COVID-19 pandemic. But we have to have some knowledge and skills for practicing telemedicine, and we have to have also an infrastructure for technological infrastructure and logistical support to apply telemedicine with a good quality. Each country also has some legislations or some guidelines to have to be applied to the practice of telemedicine to keep it safe and proper. The WHO put a definition for the telemedicine should have 4 elements. The first element should provide clinical support and should overcome geographic barriers. Telemedicine also should involve various communication technologies and has to improve the health outcome. Looking into the types of telemedicine, we will find many types of telemedicine, but these are the most common ones. The live video conferencing, which is a live two-way interaction between a person and the healthcare provider using audio-visual telecommunication technology. This can be used in common diseases and in directing the patient in an emergency situation to go to the emergency room, and also can be used in psychotherapy sessions. The second type is the store and forward or asynchronous video, where there is a transmission of a recorded history or a recorded situation of a patient. This is usually done by a caregiver or a nurse or a primary care physician, and it's sent to a specialist in a remote area, in a remote place, to give his opinion. The third type is the remote patient monitoring, which is a tool used by the patient, an electronic tool. The patient enters his data or his medical data or his condition or the progress of his disease through an application on the internet, and then this will be evaluated by the nurse, a caregiver, or a physician. The last method, and it is the most important one, is the mobile health, where you use an application in the mobile to communicate the medical information. This can be done in a mobile smartphone or a tablet or any other modality, and this has a great potential to be applied in different specialties, and you can do many things with these mobile apps. So when talking about IBD or application of telemedicine in IBD, we look to the effect of the pandemic, the COVID-19 pandemic, on the pediatric IBD patients. Look here that the difference between the visits of the pediatric population in the transition clinic and the endoscopic procedures and outpatient before the lockdown and at the lockdown, you will find a great difference. And this will relatively impact the management of the disease, because if the patient didn't come to the clinic or he didn't follow up, he will develop complications. The only thing that has been preserved is the biologic infusions. They are the same before and after, because those patients know that their medicine is very important. When we explored the perception of telemedicine in Egypt, we asked the population in Egypt about how difficult it is to use telemedicine. They answered 70% of them that it is very unlikely to be difficult. So it is easy to use telemedicine in Egypt. And when we asked them to what extent do you prefer to use telemedicine, 60% of our population preferred to use telemedicine. The situation is the same in different parts of the world. This study shows that prior to COVID-19 pandemic, most of the visits were in the green area, which is the face-to-face. During the pandemic, the patient shifted from face-to-face to the telephone, which is the blue one, or the video consultations. After the pandemic, they returned back to face-to-face, but still there are some people still preferring to use the telemedicine after the pandemic. This was represented in different parts of the world. If you look at different continents, you will find most of people prefer telephone or video consultation during the pandemic. So there are too many applications to monitor IBD patients, but I have chosen only one, which is the most famous one, which is My IBD Coach. The My IBD Coach application offers modules that monitor patient every 3 months or 1 month or even 1 week if he has flare. There are many questions that the patient has to answer, and these questions will be transferred to his physician who evaluates the condition of the patient. And when these parameters exceed the abnormal values, the system gives an alarm to the dashboard where the physician can ask this patient to come and evaluate him. There is also a personal care plan for the patient, which is a summary and visualization of his health parameter. That is also depending on the patient reported outcome measures and quality metrics. There is also an opportunity for learning, e-learning. There are a lot of information that are giving to the patient about his disease, about adherence to medication, about nutrition, about the side effects and everything. So this also increases the knowledge, not only to monitor the patient, we can increase his knowledge also about his disease. The fourth module that is also present in the My IBD Coach is the communication. The module or the application allows communication directly between the patient and the healthcare provider. So there are too many options that can be done using telemedicine to properly care about those patients, especially in the COVID-19 era. So when they develop this application, they have a primary outcome to measure, which was the outpatient visit, the number of outpatient visits and the quality of care over a 12-month period. And they measured many secondary outcomes like adherence, quality of life, knowledge of the patient's self-efficacy, smoking, and disease outcome, flares, etc. They used the quality of life measure questionnaire, which is a short IBD questionnaire, which measures the bowel symptoms, the systemic manifestations, and emotional health and social functions, and gives a score between 10 and 70. The lower the score, the lower the quality of life. The results showed that there is improvement in the outpatient visits in the group of telemedicine rather than the group of the standard care, and also there is improvement in the number of telephone consultations. When looking to the secondary outcome, the medication adherence was much better in the telemedicine group than in the standard care group, and the knowledge also was better in the telemedicine group. This study also shows that there was decrease in the hospital days for IBD patients when they use telemedicine, and also there was also decrease in the emergency department days for IBD patients, and those days which were decreased here increased in the office or the IBD clinics. The fecal calprotectin can be also incorporated in the applications. The patient can use this kit to measure his fecal calprotectin and use his mobile to capture this result and send it also to the physician. So they can do the investigation at home and send it through the application. This is one of the applications, the mobile applications, that has extensive information, and the patient can apply his information and communicate with his physician. This is for UCLA healthcare system. There are some limitations of telemedicine, as everything. These are mainly about the restrictions of reimbursement. There are some rules in the USA that the patient, when he is using telemedicine, the patient should be outside the metropolitan area. And there are specific sites where the patient can go to consult his physician using telemedicine, and the physician has to have a specific license and has to have a specific like insurance against malpractice, and there should also be some security in the connection between the patient and the physician. The technical limitations are always available everywhere, so we have to make sure that we have all the technical support available to apply this service. And also, old patients may not be able to communicate electronically like the younger population. And also, absence of formal clinical examination is one of the limitations of telemedicine. So, collectively, the limitations of telemedicine include the the time that physician has to offer for the patients to practice telemedicine, and the question if is self-management by the patient, is it trustable, or is it enough to do it through the application, or we need more control on our patients? And the last thing, how should the payment will be done through the insurance companies? This is the current evidence for e-health in IBD. There are many strengths, and there are many weaknesses, and there are threats, and there are opportunities. We have to work on this in prospective trials to properly practice telemedicine in IBD. So my take-home messages: telemedicine is highly accepted by IBD patients and their healthcare workers, and telemedicine systems is relatively safe, and patient-reported quality of healthcare remained high. Telemedicine resulted in a reduction in outpatient visits and admission to hospital and increased adherence to medication. Self-management tools might be useful for improving care of IBD towards personalized and value-based healthcare. And thank you.
Thank you, Dr. Mohamed, for your elegant lecture and very hot issue about communicating with the patients and the doctor nowadays. We will go for questions. Yes. For the floor. Or, okay, I have a question for you. How do you find it easy for the patient to communicate with the doctor? It's very applicable to have a mobile communication or something like that. But can you depend on what the patient tells you about the telephone or about a mobile application? Can you depend on that to change the strategy of treatment or add medicine or shift for another investigation? In our area here in Egypt, the patient find it very easy to get the doctor. He can get you on a mobile phone or on WhatsApp and can get you anytime. But can you depend on what he tells you, that I have diarrhea, I have a bleeding rectum, I have fever, I'm not going well, or he's telling you I'm excellent, everything is okay. Can you depend on this for this debate, the telemedicine?
Okay. We cannot replace the actual clinical visits and clinical examination by a telemedicine service completely. Okay, let us agree about that. The patients, they can inform you about some solid information about the disease, and you depend on that. But if the information cannot be assessed by the patient, you cannot trust that. For example, if you give them the kit for fecal calprotectin, you ask them to prepare the stool and do the test and capture it, you can rely on that. But if you ask him about a place of his abdominal vein, you cannot trust his description. So this is one of the limitations of telemedicine, which that you cannot gather all the information that you can trust from the patient. You can just depend on solid information given by the patient.
Okay.
Dr. Mohamed, that's very interesting. But I'll just to go to very basic thing. Do you think this is prime for use in Egypt? Just transforming the medicine to home delivery as everything, or it is still something for the future when the patients and the doctors are well aware of what's going on?
Regarding the application in Egypt, telemedicine is practiced already in Egypt. Although it is not allowed by the syndicate to practice telemedicine, I know academic centers and private centers practicing telemedicine in Egypt. I think it's applicable in Egypt, and it is a demand, and most of our population accept it, whether physicians or patients. But we have to put the rules and legislations and the bylaws, to practice it safely and effectively. This is our rule. But applicability, yes, it's applicable and it's already practiced in Egypt. I know some universities and I know some private centers practicing telemedicine.
Thanks, Professor Mohamed. Any question?
Thanks, Dr. Mohammed, for this hot topic. I want to ask you about the medical legality. If any medical legality
Yes.
of telemedicine.
Yes.
A patient come to you and say that you drugs you prescribe make me worse,
Okay.
and you will not see me.
Yes, that's why I said practice of telemedicine in Egypt is not allowed by the bylaws of the medical syndicate. I'm a member of the council of the Cairo Medical Syndicate, and I applied already a request to examine the proper telemedicine practice in Egypt and to put some bylaws to that, and they are discussing that. But we are keen to keep the service as low as the lowest harmful level. I mean, we should not do any harm. We should not do any harm. We can practice telemedicine for video consultations to ask the patient about the symptoms like stroke or weakness and divert him to an emergency room or a hospital. We can do that in some psychotherapy. We can do that in some dermatological conditions, but we cannot do it in our practice like in acute abdomen, for example. So the medical legality is very important, and we have to have bylaws and legislations for that. And this is a long way to do. This may consume like 1 year to have the bylaws, detailed bylaws to protect us. And we should have, like in the US, health insurance for the people who are practicing, the doctors who are practicing telemedicine. You should have a special insurance against the medical malpractice.
Thanks, Professor Mohammed. Now it's